Today's webinar is what to know about follicular lymphoma transformation to diffuse large B-cell lymphoma. We chose this topic because sometimes follicular lymphoma can transform to more aggressive forms of lymphoma, and we want to make sure patients like you are aware of this possibility and know what to do if it happens. For today's webinar, we are very excited to have Dr. Matthew Cortese join us. Dr. Matthew Cortese is a lymphoma specialist and assistant professor of oncology and cancer genetics and genomics at Roswell Park Comprehensive Cancer Center. His research focus is to develop a better understanding of the mechanisms of treatment resistance for lymphoma, as well as to investigate the molecular mechanisms by which low-grade lymphomas transform into more aggressive high-grade lymphomas. Dr. Cortese is actively involved in clinical trial design and implementation and ongoing efforts to provide better treatments and hope to patients. And with that, I will turn it over to Dr. Cortese for his presentation.
Hi, Hannah, and hi, all. Thank you so much for joining us today. It's my pleasure. Hannah, I got to meet at ASH after an oral abstract I'll be talking about a little bit today that had to do with transformed follicular lymphoma, and absolutely thrilled to be here with you today. Just going to pull up my slides. Y'all see my screen okay?
Yep, that's
perfect. All right. So today I'll be talking about follicular lymphoma, which ranges from indolent to aggressive, and there's going to be some spectrum in between that I'll be discussing a little bit today as well. My name is Matt Cortese. I'm an assistant professor of oncology in our lymphoma section in the Department of Medicine, and also a molecular enthusiast in the Department of Genetics as well. Here are my disclosures. So today I'll be talking about lymphomas in general, as well as the initial workup. I'll be talking about updates in the classification of lymphomas, and then I'll be discussing a clinical case. And then I'll be discussing the indolent portion of follicular lymphoma called classical follicular, as well as transformations of follicular lymphoma, as well as treatment options and some data associated with those. And then, of course, want to leave some time for questions and answers. So first, what are lymphomas? So lymphomas are a heterogeneous group of cancers of the lymphatic system. And you may hear the term lymphocytes or B cells and T cells. These are all white blood cells that basically reside throughout our bodies. As you can see from this picture of the lymphatic system, it's really everywhere. And the word itself comes actually from Latin and actually from Greek. So nympha was like in Greek mythology were these aquatic beings that lived in pure water, and the Romans, I guess, adapted that to be lympha, which is what they used for pure water in their language. In Latin, oma means tumor in Greek, and so it's a tumor of this aqueous or water-like immune system. Lymphomas commonly arise from B cells. B cells make antibodies in their normal biology. I like to talk about white blood cells with patients as being akin to the military. So you might imagine, white blood cell count, for example, would include the full, array of the Defense Department. And then you might say that the B cells are like the Air Force. They make bombs and bomb bad guys, basically, and infectious organisms and things like that. So the other 15% or so of lymphomas are actually made of T cells, which directly kill other cells that are infected with viruses or viral or fungal infections in nature. So these are anti-cellular components of the immune system. And they might be like your special forces, I suppose, in that analogy. So the discovery, quote unquote, of lymphoma. So obviously, unfortunately, people have had cancers for thousands of years since we've had DNA in our bodies. There's been the ancient Egyptians were one of the first to describe some tumors of the lymphatic system as early as 3000 BC. Cancers were kind of first described. People didn't really have microscopes or blood chemistry tests, or certainly multi-omic molecular profiles or sequencing like we have today. And so really it took until 1832 for Dr. Thomas Hodgkin to describe the morbid appearances of the absorbent glands in the spleen. And he was the first to describe a particular type of lymphoma that we now use the eponym Hodgkin's disease or Hodgkin lymphoma. And there's been, as you can, I'm sure, appreciate, there's been an immense amount of progress over the last 60 years, and really over the last 5 or 10 years, frankly. It's been exploding in complexity. It's been a privilege to be part of this field as we help make better treatments, better prognostic tools, et cetera. Now, how did lymphomas present? They can be extremely aggressive. Inflammatory B symptoms, we call. So B symptoms are basically inflammatory symptoms, and there's 3 unique components of this. So fever that's unexplained by infections or other known syndromes or medications, for example. Unintentional weight loss, specifically defined as more than 10% of body weight within the last 6 months. That's, again, unintentional, not like taking Ozempic to lose weight, at the behest of your primary care doctor or anything like that. This is, unexplained and unintentional weight loss. We talk about night sweats. Usually they're drenching, although with indolent lymphomas, you'll hear, and patients can, of course, feel some kind of non-drenching night sweats. And we often will say, can you live with it or not? And if you can't, then we talk about treatment for those. Lymphadenopathy, you may see in our notes, doctor's notes in your visits. Lymphadenopathy just means enlarged lymph nodes or swollen glands. Palpable just means we can feel them on exam. If they're rapidly enlarging and causing compression problems, that's obviously not good. It's a reason for treatment. They can also, very high-grade lymphomas can actually break apart spontaneously. So we call it spontaneous tumor lysis syndrome. In the context of follicular lymphoma, that can rarely occur in things like double-hit lymphoma, which I'll talk about a little bit later, and may also be associated with treatment. So high-grade lymphomas where you start chemotherapy, for example, when those cells die rapidly, which is a good thing, you have to look for chemical changes in the blood, for example. Compression syndromes, of course, if you have a large mass, an oma throughout your body, it causes pain, neurological problems, and organ dysfunction. If it's just large enough that it's going to cause problems soon, those are all reasons for treatment. Pleural effusions, fluid accumulations throughout the body. Pleural means like lung or chest cavity. That would also be a reason to treat. There can also be changes in blood counts. There can be antibodies that are made by lymphoma cells that can cause problems. Most dramatically, that would be like hyperviscosity syndrome, or having almost no red cells or no platelets because of autoimmune problems there. We can treat lymphomas and take care of those as well. And then there can be infections, of course, throughout treatment, which are a problem. Indolent means low grade, and grading means growth rate. So basically, if you hear and see high grade versus low grade, we're talking about how many cells are dividing under the microscope at any given snapshot in a biopsy, and basically how fast these things tend to grow. So many of these lymphomas, including classical follicular lymphoma, really grow very slowly, typically over years. More aggressive lymphomas can grow within weeks. And so there's a very broad array of presentations. As far as the initial evaluation for lymphomas, obviously we have to stabilize the person in front of us. If we have symptoms, we treat those symptoms immediately. Rapid medical treatments and workup, and potentially hospital admission for a dramatic, rapid onset presentation with problems. If things are non-urgent, we tend to hold off on steroids, but if it's an oncologic emergency, some compression syndrome, we will start steroids even before a biopsy, but you may hear us say, let's try to hold off on steroids or treatment until we have a conclusive piece of tissue to really inform what's the best treatment, and give prognostic information as well. We do a history and physical exam, blood work. Fortunately, it's not uncommon for a new patient in our clinics to have 20, one poke in the arm, but 20 little tubes of blood to basically give us the full amount of information we need to help the best we can. And then just briefly, I want to talk about lymphocyte counts. When you look at the white blood cell count, then you look again at the little breakdown, it's called a differential. You look for the lymphocyte counts, and if it's crazy high, that can be usually a sign of cancer in the blood, for example, all of that being treatable. Then we will often ask for images. PET scans is the standard of care. We use something called Lugano staging criteria, which is basically a way to use PET scans to really identify areas of disease. PET imaging or positron emission tomography uses a fancy sugar frankly, it's called FDG. Basically, this tracer is able to be uptaken into healthy tissues that use lots of sugar. So like the heart, for example, like in this would be stage 2, but this is a normal heart. This is a normal bladder, actually, normal kidneys and collecting systems, right? So there's actually a lot normal when you see these images, but what's abnormal are going to be areas in between these organs that we know take up lots of sugar. And in these images, this is showing you areas of involvement by lymphoma. And staging is important. I'll leave it at that for now. But if you look up Lugano criteria, you'll see how we stage lymphomas. There's this other thing on reports for PET scans that I think it's important to highlight. It's called an SUV. SUV stands for standardized uptake value. An SUV max is usually the hottest or brightest value, and that basically indicates in many cases can be high rapid growth rate, or at least means rapid uptake of sugar. And typically, if it's less than 10, we will be reassured against any form of high-grade transformation, basically. So if you get a PET scan and the SUV max is all less than 10 and things are growing rapidly, things like the lactate dehydrogenase or LDH in the blood hopefully is low or normal. But oftentimes there can actually be false positives as well. So if you do see a report and the SUV max is over 15, it's not uncommon actually to get a biopsy, recommended at least for a biopsy to look for transformation. But there's actually quite a large proportion of these that are frankly false positives as well. So I just want, as a word of caution, we need to, of course, look at those areas and try to get a biopsy to rule out a more aggressive form of transformation of lymphoma. But there also are plenty of cases where these can be falsely positively elevated. But yeah, so typically we will try to target that area with the brightest SUV max that can be done safely. Typically that's done with a core needle biopsy with our interventional radiology teams. We do prefer a small surgical excision or removal of a full lymph node. And what we're looking for is really the architecture of that lymph node. And we're trying to see, are some of the cancer cells infiltrating or taking over that whole lymph node, spreading aggressively, kind of, steamrolling everything in their path. And that would be a sign of a more aggressive transformation, like a diffuse large B-cell lymphoma. It's called diffuse large because these cells are diffusely spreading through a lymph node and they're usually large in size. Follicular lymphoma refers to the follicle, actually, which is actually a particular area often referred to as the germinal center or part of the germinal center, where B cells are basically born and, where B cells go to school, I should say, excuse me. We often will also ask for special molecular tests. This usually includes things like fluorescent in situ hybridization or FISH, not like you go fishing for in April here coming up for trout, but looking for color changes where chromosomes have mixed in weird ways, then that can give us information about growth rate and clinical behavior. And then we also certainly recommend consulting with a subspecialist like myself for lymphoma, and we will help guide you through a care plan. Basically, do we treat from the beginning or can we actually watch for a while? And watchful waiting is very common for low-grade lymphomas, at least in the beginning, with close follow-up, of course. We also always talk about clinical trial options and specialty tests. These are all very important to be aware of. And I think Roswell's jingle nowadays is just spend one day at Roswell, so we can give you some of these kind of specialty input and insights. But plenty of our community colleagues are fantastic at what they do and to provide excellent care, and we trust them and have a great working relationship with them. So have faith in your local team as well, but we're happy to kind of weigh in for our nerdy subspecialty angle. Many, like I mentioned, can be monitored expectantly in the beginning. This is Dr. Hernandez from, I think, 20 years ago. Deb actually was our secretary, retired. So here's a stock photo I thought was fun to share. Keep moving on. So just briefly, this is another algorithm. We're going to share these slides, so you don't have to look at every word as we go, but basically just want to show you some of the highlights. So fine needle aspiration is a small little tiny needle that basically is the least effective way to get a biopsy. So a core needle is, I'll show you in a moment, gives you a larger fingerprint basically to really see the architecture of these cells. An FNA, you might get kind of confusing information where you can see the chemical signature on the surface of these cells, like by something like flow cytometry or immunostains, we call them. But you actually lose that architecture completely because it's almost like you put those that lymph node through a little blender, right? By sucking up through too small of a straw. So the least effective biopsy we often recommend is called the core needle biopsy. This is typically a larger gauge needle, and so in basically interventional radiologist or sometimes a surgeon will do small passes through the lymph node with lidocaine and other ways to numb the skin and deeper tissues as well. And this gives us much more information that can really clarify diagnosis and help get you the best possible care. And then the ultimate is an excisional biopsy, which gives you a whole block of tissue to look at. And as you can see, there's just large, architectural features, histologic features, we call them, on each slide, basically. And so you can get a lot more information about what's going on. And I just mentioned histopathology, histochemistry. This just means microscopic appearance and some of the chemical signatures. So as you look through a pathology report for follicular lymphoma, you should expect really all of these to be positive and to varying degrees. Particularly CD10, it's a germinal center reaction marker. CD20 is a target for rituximab and obinutuzumab and other treatments like the bispecific antibodies I'll talk about in a little bit. And Ki67 is one of the growth markers as well. So I mentioned grading. This actually measures mitoses, basically. So how many cells are dividing at once. All right, so just want to talk a little bit about how we subtype lymphomas nowadays. So this actually changed a little bit in 2022, which is already 3 years ago. Seems like yesterday. We actually, by my count, we have 88 mature lymphoid malignancies, and there's more if you count things like ALL and plasma cell disorders like multiple myeloma. There are 49 mature B-cell lymphomas. 2 are Hodgkin. Really, I think 1 is Hodgkin, to be honest. NLPHL is, I believe, kind of like a follicular lymphoma. And 47 non-Hodgkin B-cell lymphomas. And there are actually 39 types of T and NK cell lymphomas. So lots of complexity. And there likely are going to be many more of these subclassifications as we get better at using our best molecular tools to break these cancers apart into different buckets and with different treatments that are better. Here's just a quick list of all of them. The reference is below. It's publicly accessible information. I'll be talking about follicular lymphomas as well as some of the transformations. And just wanted to highlight that transformations of indolent B-cell lymphomas was actually a new addition as its own unique entity. And follicular large cell lymphoma was actually also a new entity as well. Here's another easier to read version of that. I'll leave that for now. And then just briefly, here is a list of the T-cell lymphomas for reference and my own breakdown of aggressive and indolent T-cell lymphomas as well. The way these cells differentiate or don't differentiate is actually very interesting and actually lends itself to the name of each of these subtypes of lymphoma. So where they live in a lymph node and which kind of flavor or which age or demographic group, I guess you can say, of a lymphoid cell has led to the growth of that cancer. And so in the case of follicular lymphoma, it actually has to do with this concept called the germinal center. Like germline is, from the very beginning, right? So kind of like basic middle school type of pathology where B cells learn how to basically identify potential bad things in the blood or in the lymph nodes more specifically, and try to make antibodies against them, basically. So that's where a germinal center reaction occurs. We make many little lymphocytes and B cells that actually 99% plus never make it to become a mature long-lived B cell because they make these ineffective and non-functional antibodies. And there's this concept of positive and negative selection I'm not going to bore you with today, but it's very interesting for me and most of us lymphoma nerds out there. Follicular lymphoma has these genetic mutations, so you may read about some of these other mutations throughout. Some of them have important treatment implications and therapy resistance implications, for example. And in the case of EZH2, it now has a targeted therapy for it, which I'll talk about. But basically, this is a curiosity for the moment, but I'm happy to answer any more of these kind of detailed nitty-gritty questions as well. Follicular lymphoma, which we'll be talking about today, is the most common indolent lymphoma, so slow growing. CLL, SLL is another one of my specialties, is the most common leukemia, CLL specifically. And then diffuse large B cell is the most common lymphoma overall, and obviously the most common fast-growing lymphoma. This is just a brief slide about some of the demographics, but typically non-Hodgkin lymphoma is relatively infrequent, but as a group, it is I believe it's the 8th most common group of cancers. This is a little bit outdated now, but basically we do see plenty of lymphoma. And typically it's a disease of older adults as well. So non-Hodgkin lymphomas typically occur in patients in their 60s. And of course, in young folks, the Hodgkin lymphomas and ALL are more common. But I've seen follicular lymphoma in patients even in their 20s. So not common, but does occur. Now I'll leap into a more clinical presentation. So I wanted to talk about one example as a teaching case. So we have a 65-year-old gentleman who was previously healthy and experienced a slowly enlarged left-sided lymph node over his neck for the last 9 months. He lost 10 pounds over the last 6 months, despite otherwise having a good appetite, not in any other offending medications or having any known infections. He reported some occasionally drenching night sweats that were really starting to affect his quality of life some, but not enough to rush to the ER or anything like that over the last month, and then some mild fatigue. On exam, he has a 3 centimeter, about 1.5 inches lymph node on his left neck, and some enlarged, minimally enlarged lymph nodes in his groin as well on the right side. He has no big organs or masses in his belly. His labs are otherwise normal. A PET scan is done and basically shows pretty extensive, or you might hear impressive, lymph nodes in his left neck and some masses throughout his body as well. As far as the staging again, basically you might hear, so staging is basically, stage 1 rather is 1 radiation field or 1 lymph node station. That potentially would be even curable, frankly, with radiation therapy, although the success rate is certainly less than 100%. Stage 2 disease is defined by 1 or more lymph node groups that are all above the diaphragm or all below the diaphragm. So ipsilateral, we say, to the diaphragm. And then stage 3 disease would be lymph nodes or disease involvement on both sides of the diaphragm. And stage 4 would be usually organ infiltration or peripheral blood involvement or marrow involvement. And briefly, the night sweats, feverish chills, those B symptoms I mentioned in the very beginning, that would be a B designation. So say a stage, in this case, a stage 3B. Lymph node biopsy was done, as I showed before. It's like this, and we have a diagnosis now of classical or low-grade follicular lymphoma. So then, of course, we have to define the stage and risk stratify and then start treatment. This particular translocation, we call it 1418, is called BCL2. I'll touch on that as well. But that's one of the hallmarks of this classical follicular lymphoma. So as I mentioned, it's the most common slow-growing form of non-Hodgkin lymphoma. It's about 70% of all of those cases, and the second most common lymphoma overall, about 15% of the whole mix of all lymphomas. So very common. I mentioned already that it's this expansion of these germinal centers within lymph nodes. There's complex biology that goes with that. The WHO 5th edition, which was in 2022, as I mentioned, did change grade 1 to 2 and grade 3A, actually lumped them together into classical follicular lymphoma. So if you had heard about grade 1, 2, and grade 3A in the past, we do think grade 3A is slightly more aggressive overall, and there is some nuances there I'm happy to talk about later. And then grade 3B, as it used to be known, is now called follicular large cell lymphoma. Basically, it's a transformation from the get-go. Follicular lymphoma in general has a favorable prognosis. I'm going to try to teach you all to be oncologists with me and hematologists, and I'd like you all to teach me to be patient-minded as well. But I'm going to start talking about some of these curves we call Kaplan-Meier curves. On the y-axis, we talk about some kind of outcome. So in this case, it's going to be the probability of being alive, which is the most important outcome. It's our gold standard for all clinical trials, for example. We all want to help patients live longer, right? And obviously not progress. That's called progression-free survival. I'll talk about that as well. And then basically on the x-axis, there's going to be some kind of time point. So if you look at the overall survival for all patients with follicular lymphoma, again, with a median diagnosis age of around 65, 68, the chance of being alive is well over 50% 15 years later. And this is actually pretty historical old data. So with better treatments nowadays, this is actually going to be a curve that's going to be flatter or higher up essentially over time. So and then we also start to break things apart into different risk groups. And you might hear about things like the FLIPI score or Follicular Lymphoma International Prognostic Index. There's a FLIPI-2 score. That's for up to your oncologist to calculate that for you, go over it with you. We also talk about staging as being important for overall outcomes. Although even advanced stage, stage 4B disease, we do treat readily and very, very effectively. So even if you're given that kind of a stage, I want you to know that our treatments are super effective and overcoming a lot of these things now. I wanted to introduce, look at this concept of POD 24, progression of disease at 24 months. Dr. Carla Casulo just down the road led this LymphoCare initiative and kind of coined this term. This is a term, so for patients who actually require treatments with some form of chemoimmunotherapy, not just rituximab, but something like bendamustine or CHOP or something similar, if it comes back within 2 years, that's a marker for chemo resistance or a higher growth rate. And that's something that's concerning. It's about 15% of cases and highly treatable, but it also just portends some element of stubbornness or faster growth rate. And all of these factors are prognostically important. Follicular lymphoma is currently considered incurable. We're working on challenging that. CAR T cell therapies, which I'll talk about a little bit more in detail, is a new approach over the last 7 or so years for mature B cell lymphomas, and allogeneic stem cell transplants or bone marrow transplants may cure some, and we're trying to increase that fraction all the time. This is just another quick summary slide. I'm going to keep moving on. I've talked about these points. So how do we treat follicular lymphoma as far as low-grade or classical follicular lymphoma? We generally prefer a combination of a moderate intensity chemotherapy called bendamustine with rituximab. This does not cause hair loss, does not affect the heart as R-CHOP would do. R-CHOP is FDA approved and used often for diffuse large B-cell lymphoma, and that's been challenged recently with other regimens, which I can talk about another time. But basically, there were 2 studies in 2014, Still and Bright, which I've referenced some of them here, and they should be available to look up as well, where basically BR beat R-CHOP on the basis of both efficacy and tolerability and safety. So for us, it's the preferred frontline approach because it actually lasts longer and has fewer side effects overall. So BR, you may hear, is a recommended option. And I agree with that for most cases of low-grade classical follicular lymphoma. I'll leave it at that for now. Basically BR then after that became one of the frontline standards of care, we call that. So one of the best treatments. It's the marker to beat, the high water mark for treatments. Another option is lenalidomide and rituximab, or R squared. It's called R squared because it's lenalidomide is also called Revlimid. R squared is also approved for marginal zone lymphoma, large cell, mantle cell, and some central nervous system lymphomas because it can actually penetrate the blood-brain barrier. For the infrequent presentation of someone with classical follicular lymphoma with central nervous system involvement, where I know bendamustine won't work effectively, I'll often look for R squared actually as my initial treatment or enrollment on a clinical trial. This was an MD Anderson cohort study, similarly effective with BR, but there are some more side effects which I personally don't like. There are, just like chemotherapy, there can be cytopenias, low cell counts. There can be infections. A unique toxicity is the potential risk for blood clotting. And so there's always a need to take aspirin or some form of anticoagulation with it. Skin rashes, diarrhea, fatigue, etc. And then for prolonged use, typically over a year or 2 years is done infrequently. It can also select for resistance mutations like TP53, which chemotherapy also can do as well. So looking for ways to mitigate those risks. Not everyone certainly develops a TP3 mutation on these drugs, and they're very, very effective for many, many people and for years. But just something to be aware of when we're deciding on treatment options. So this patient, we said, has classical follicular lymphoma, stage 3B. We did his FLIPI score. It's a FLIPI 3, which is higher risk. Do we need to treat him, right? So we look at something called the GELF criteria. GELF is it's a French consortium, Groupe d'études lymphoma folliculaire. I think it's my best French I can do today. This looks for bulk, basically. So one tumor more than 7 centimeters, or 3 more than 3 centimeters that are in different areas of the body. And then we look for any symptoms, of course. It's with all lymphomas that we are deciding if we need to treat or not. Symptoms that are changing quality of life, significantly. So a little tiny sweat here and there, very tolerable, non-drenching. Oftentimes we'll encourage ongoing surveillance. But if people are drenched in sweat every night or a couple times a week, it's affecting their marriage or their laundry schedule. Those are definitely reasons for us to advise for treatment, especially if they persist beyond, say, an infection that occurred at that time. If we see large, organ involvement, spleen involvement, organ compression, fluid where it shouldn't be from the lymphoma, or if we see markers for very aggressive disease or platelet counts and other cell counts being affected, those are all reasons to offer treatment. This is, I think, a really useful slide that I made. I may be so bold. Patient-oriented. So this is what to ask your oncologist if, like, at your appointment, usually your first or second appointment. So first, I would ask, what is my diagnosis? What subtype of my diagnosis do I have? Where is my cancer, and what stage am I formally? Is this curable, non-curable, treatable, non-treatable? I will say that there's really all of lymphomas are treatable, frankly, certainly in the frontline setting or initial treatment setting. I would ask, can I survive the treatment is the other question, right? And what are some of the risks and some of the side effects? And of course, you want to ask then, what are some of the alternatives, right? So what are the risks and benefits of those alternatives? This is part of what we call informed consent. And so that should be really a bedrock for that discussion, that shared decision discussion that's so important, where you discuss what's out there so that you have that full packet of information to make the best decision for yourself. I would also ask what would happen if I did nothing. Like if I just didn't go to any appointments, I just ignored this thing, what would happen to me? And then what's the estimated prognosis in that setting, as well as with these different treatment options? If I can't cure it, do I need the treatment right now is another question. What signs and symptoms do I have to monitor for? When do I call my doctor, my nurse line, triage line? Can you describe how I might feel during the treatment, and how do I feel after treatment? And how long does it take to recover? What clinical trials are available, either here in my immediate area or in my region, or even internationally or nationally, to help folks. There is a website, it's government run, www.clinicaltrials.gov, which is filterable, just like you're shopping on Amazon or somewhere else. You can actually look and kind of sort by disease characteristics, where you live, eligibility or inclusion criteria, things like that. So very, very important website to know about. All right, so for our gentleman, he's had enlarged lymph nodes, he's got some B symptoms, so we offered BR. We did give some medicine to help prevent shingles reactivation for all of us, or most of us, who are too old to qualify for the shingles vaccine. And basically, we also give, for most patients, at least over 65 or with some low cell counts going in, a medicine called Neulasta or pegfilgrastim, we call it. It's a long-acting medicine that's used to boost up your white blood cell counts, the neutrophil counts. And this gentleman got a complete remission, or CR. You might see that listed. And here he is. He's giving you the thumbs up. Now, let's say, based on the data here, 9 years. I think it's like at the end of the chart here. So he finally has he's like one of these patients, I suppose. He's still in remission until the very end here. And he's now 74 years old. He now has recurrent follicular lymphoma, some uncomfortable swelling under his arms, some more night sweats and fatigue, not happy about it. PET scan shows a lower SUV max, so we're kind of reassured against transformation so far. It's the clue coming up. And biopsy of that confirms a low-grade recurrence of the follicular lymphoma. So what are some of the options available for this gentleman? So R squared is, so if you got BR up front, we still give R squared in the relapse setting. The time to next treatment, how long it works, how well it works is a little bit less, but it still works incredibly effectively well. Median follow-up for about 2.5 years. The time to progression was a little over a year. And that's why there's emerging studies actually looking to build on this. So both in the frontline and the relapse follicular lymphoma setting, you're going to see trials like EPCOR-1, for example, is open at Roswell Park. This is using epcoritamab, which I'll talk about in a moment, used for transformed disease, approved for large cell lymphoma and follicular lymphoma. You're basically adding some of these drugs together, basically. So EPCO plus R squared, for example. But R squared by itself is the control arm, right? Because it's a very effective option for many people. The Rosewood study was a newer study that just came out a couple of years ago. This is using a BTK inhibitor called Brukinsa, or zanubrutinib is the generic name. This is a second-generation BTK inhibitor that was studied with a monoclonal antibody against a surface marker called CD20, similar to rituximab, but this drug is called obinutuzumab. Very effective antibody, and this was studied in combination in this Rosewood trial. This has been useful for me in my practice for patients with multiple relapse disease, especially those with progression disease within 24 months. And I need a bridging therapy, say something like CAR-T, or just something that, if they're not ready for CAR-T, too toxic, et cetera, we'll talk about that as well, or don't need it. This is has been a very effective option as well. So this was approved. It's also approved for CLL and SLL, for Waldenstrom's macroglobulinemia, or LPL, and marginal zone lymphoma and mantle cell lymphoma. So this was studied, again, back to our Kaplan-Meier curves, teaching you to think like an oncologist. We like the best curves, of course, are going to be 100% duration of response for forever. That's not always possible. For our Hodgkin lymphoma trials, we're closer than most. It's 92 or so percent years later. But in the follicular lymphoma setting, and this is in relapsed, again, relapse setting, zanubrutinib, or ZO in this graph is the blue line. So basically, half of patients are still in remission, over 3 years out, whereas just obinutuzumab, which definitely is effective as we call it a salvage option, something that's useful in the short-term setting to get disease control right away. We do see earlier relapses basically with just that antibody alone. And so we look at the overall response rate, how many people actually benefited, actually had some reduction in their tumor, almost 70% in ZO compared to 46% with the antibody alone. So also higher response rates overall. Of course, not a free lunch, unfortunately, with any new medication. When you're adding drugs into a big pile, those side effect profiles can add up, and you want to be well aware of those. Low cell counts, infection, atrial fibrillation, and bleeding concerns are a class effect of the BTK inhibitors to be aware of as well. So oftentimes if people come in and see me and they have AFib, are on antiplatelet therapies, or have extensive heart problems or something like that, this is something I try to steer away from if I have other options. But even in those settings, I can typically get away with things safely with very close monitoring and cardiology follow-up. Now to CAR T-cell therapy, I've teased this a little bit. CAR-T is chimeric antigen receptor T-cell therapy. It's often abbreviated as CAR-T or CART. It's an intensive and FDA-approved form of treatment, and it actually uses engineered T cells, which are collected from the blood. This graphic's a little bit of a slight misinformation. Usually the line is actually going to be a larger line up, closer to the chest, like one of the brachiocephalic veins or subclavian veins. Excuse me, temporarily for about a day for T cell collection. That bag of isolated leukocytes full of T cells is then shipped off to a lab or to an academic medical center like Roswell, where we're making our own CAR T cells. And basically, there's a gene that's inserted into these T cells that enables the production of this thing called a CAR, which is the actual antigen receptor. Normal T cells require this process we call co-stimulation. They depend on other cells to activate and ensure that this truly is a cell that needs to die. Obviously, unfortunately, with cancer cells, those T cells that are circulating in the blood and throughout tissues are not doing the job, right? The whole definition is kind of it's an immune dysfunction that's led to the cancer in the first place. This is one of those ways that's uh, engineered basically to overcome that and basically enable these cells when they go back into the body after this process of leukapheresis and then manufacturing, we call that, and quality control. We put them back in patients' bodies, and these now activated T cells are able to go in, find the target, in this case CD19 for all these approved products, and get to work basically and cause this inflammatory reaction and kill the cancer. We hope. In the majority of patients, that certainly is what happens. The ZUMA-5 study was the first FDA approval, the first CAR T cell product. This is also known as Axi-cel or Axicabtagene ciloleucel, or Yescarta is the brand name. This was an open label phase 2 trial for patients with relapsed refractory follicular lymphoma and marginal zone lymphoma who had received at least 2 prior lines of therapy. Let's say for our patient, it was BR and R squared. R squared only lasted so long, so he's being looked at for cell therapy. There were 153 patients treated. The overall response rate was 92%, so it's a pretty darn good initial response. I want people to, when you look at data with CAR T cell therapy, especially, I want you to look at a couple other things though. So the initial overall response rate is really critically important. Is this working at all? Is my cancer reducing? But I also really want to encourage people to look at around 6 months or so out. So that's when the initial, light chemo that generally in the commercial products comes with CAR T cell therapy. The chemo effects themselves actually can kill the lymphoma cells. You want to really see a more durable response with cell therapy. It's a very expensive, complicated, logistically complex, and potentially very toxic procedure. Things like, this inflammatory reaction called cytokine release syndrome, this immune cell associated neurotoxicity syndrome, or ICANS, neurotox. About 20% of patients had to come into the hospital for some form of confusion. So, very safe, very effective, but certainly is intensive and complex. And so just to be aware of, in this case, if you look at the progression-free survival, so time until relapse, and you look at this is actually measured in months. 6 months, we're still talking 80% of people are still in remission. So these are, excuse me, very typically high risk, multiply relapsed patients that were on these trials as well. And so CAR T really can lead to these more durable responses. And then you're looking out, over 2 years, and we actually have longer follow-up now. You're seeing, well over 50% of people are still in remission. Unfortunately, in the marginal zone lymphoma setting, patients had relapsed earlier, and it was not FDA approved for marginal zone, but Axi-cel was approved for follicular lymphoma in this setting. And I want to also mention that CAR T cell therapies are also approved for transformations, which I'll talk about as well in a little bit more detail in a moment. So excellent efficacy. We had our 3-year follow-up as advertised. Still, close to 50% of people are still in remission, well over 3 years later. This is actually going on 4 years there. Hopefully curable for some of these folks, but we're going to need probably 10 more years to really see if that's the case or not. Oftentimes, when you're referred to a transplant center or a cell therapy center, there will be a discussion about, is chemotherapy the best option for you? Use up all chemo options first before we talk about CAR T cell therapy. So certainly if patients get, say, once treatment with rice, for example, more intensive large cell type salvage chemotherapy, and their cancer is melted away completely within, say, 2 cycles, autotransplant is a really good option actually for consolidation first for these patients. That said, though, if there's progression of disease within 24 months, or if there's kind of a partial or weak response to chemotherapy, as a challenge, kind of initial treatment, then CAR T actually was looked at, and this is a looking back in time kind of a study, retrospective study, but it did show that CAR T cell therapy, at least based on the ZUMA-5 cohort, was better than the traditional chemotherapy-heavy, transplant-only cohort from the past. We have better supportive care. There's a lot of other caveats to this, but does seem to suggest that CAR T is a better option for chemo-resistant lymphomas, and that's a theme in the large cell setting as well. The other FDA-approved option is lisocabtagene maraleucel for follicular lymphoma. This is more recent. Huge study as well. 153 patients with CAR T is considered a large study in this context for a complex, expensive type of procedure. Overall response rate about 92% again, and again durable responses with for many a more favorable toxicity profile. And so liso-cel is also an excellent option, especially if axi-cel is scares people as far as the side effect profile. So this was also FDA approved, looks fantastic as well. I also want to talk about bispecific antibodies. Again, this is for both relapsed follicular lymphoma, but also for large cell lymphoma as well. So this actually will cover both. Bispecific T-cell engagers, or BiTEs, is a proprietary term. Shouldn't probably have put this in the presentation, but bispecific antibodies is a non-proprietary term we use more. These are FDA-approved options, again, for relapsed refractory follicular lymphoma and large cell lymphoma. They bind to T cells, and instead of engineering that T cell, they actually use your normal T cells in the body and actually connect them directly to your tumor in the hopes that just by being close to each other for long enough, they're unfriendly, unhappy roommates. And sure enough, we do see really promising activity actually where these T cells are engaged and turn on and actually kill some of these malignant cells. We have active clinical trials ongoing at Roswell, and actually the frontline setting as well as the relapse setting where they're already approved. The first approval in this setting, this is again for just the classical follicular lymphoma and relapse, not the transformation, is mosunetuzumab or Lunsumio. This was a phase 2 study. Again, back to thinking like an oncologist, you want to see more white area under the curve. Basically, you want to see the curve to be higher up. But you also look for durability, right? So if you look at and see, so progression-free survival means time until patients have relapsed, and this is number of patients over time. You're looking at 2 years later, there's still a healthy minority of patients in this case, about 40%, who are still in remission at that time. So definitely a very, very effective option, game-changing addition, especially for people who either cannot get to CAR T-cell therapy because of logistics, costs, et cetera, access, which we're working very hard to overcome around the country. It's an off-the-shelf option that's available in clinic. I will say that one point of emphasis is with bispecific antibodies, because they drag those T cells to tumor. If I would always want to look at CAR T and meet with a CAR T treater first, because we are seeing data that manufacturing is limited and very challenging after bispecific antibody use and exposure, because those T cells are dragged to the tumor, they're dropping out of the blood circulation, and because sometimes those T cells are actually kind of exhausted, right? They've been fighting lymphoma for a while and other B cells, and manufacturing is a challenge. So I would always encourage you to think about CAR T first, and then you can always use the bispecifics after. If CAR T is just a deal breaker, then of course these bispecific antibodies are still an amazing option as well. But the durable complete remission rates are lower, unfortunately, still. Again, cross-trial comparison alert and all that. Epcoritamab is another very, very active antibody. Also targets CD20 with CD3, just like Mosun. This is also FDA approved for follicular lymphoma, but also approved for large cell lymphoma. And so oftentimes, if I get a patient who I'm concerned is mid-transformation, has been looked at for CAR T-cell therapy, not eligible, not interested, this is one of, if I have to pick between Mosun and Epco and can withstand some of the side effects, which can include these immune side effects and low cell counts, for example, and infection, aware of them obviously going in. This is a really good option that can cover both, both the follicular lymphoma and the large cell lymphoma together. Again, durable results. Again, overall survival includes patients who have been potentially relapsed and treated with other effective treatments. And so I always often look at, for a particular drug, I look at progression-free survival just as a teaching point. And then when you look at the difference between the progression-free survival rate at some time point, let's say at 24 months, and you go over here and you see it's about 45% or so in 2 years, And then you can subtract out, what is the difference between the PFS and the overall survival. And you can see that, most patients, even after they relapse here, are still going to be alive, actually. And overall survival also includes natural causes of death, things, as like aging, or hopefully that's, how we all go. Time has come, right? Right below age of 175 or something, with no side effects. That's the dream. This is FDA approved, very, very active. This drug is also being used, as I mentioned, in combination with R squared and others, as others are being studied. And then tazemetostat is a small molecule inhibitor. This actually is the first in class for follicular lymphoma, certainly, to actually modulate something called epigenetics. So how is DNA read and transcribed? This actually targets a particular mutation. If mutation is present in this particular gene called EZH2, which I would encourage sequencing at any relapse in follicular lymphoma, basically can work twice as likely to work, and the duration of response is typically better. This is a very gentle treatment overall. Just only 2 to 3% of patients had low cell counts. This is actually approved for patients who basically have no other real options, and also, for third line plus for everyone else. And that's actually irrespective of that gene. But I think it's still important to know going in, how likely is that drug to work? 70% chance or 35% chance based on that mutation. There are lots and lots of new studies coming out. There was just a publication from University of Pennsylvania, and then one of my friends at Weill Cornell, Sam Yamshon, is opening a study of TAZ and R squared, and then there's TAZ and CAR-T. TAZ seems to work really well with the immune system. And so we actually have a trial of, and I apologize, it's actually TAZ and mosunetuzumab. There's two studies. There's one is TAZ R squared, the Symphony 1 trial. That's ongoing. That looked positive. Like there's a benefit to TAZ to R squared. Preliminarily, not FDA approved yet. And then we have another study with my friend Sam. It's mosunetuzumab, one of the CD20 bispecific antibodies with TAZ in the frontline setting as well. So very hot research, blending these things together to get the best outcomes. So as far as transformations, what is this exactly? So transformations are when classical follicular lymphoma morphs into large cell lymphoma, or even an even more aggressive, more high-grade lymphoma than even large cell, called double hit lymphoma, which is defined by that BCL2 translocation plus a MYC rearrangement or translocation. I'm going to abbreviate this as TFL, or transformed follicular lymphoma. About 15% of classical follicular lymphoma patients will unfortunately experience a transformation in their lifetime. This was defined by the LymphoCare study I mentioned earlier, led by Dr. Casulo, and they looked at survival outcomes. And this is in 2015, where CAR-T was not available, bispecifics were not available. Median overall survival after transformation was about 5 years then. Obviously, that's better now with much better treatments, including Rosewood and the like I just mentioned. We treat transformed follicular lymphoma really like large cell lymphoma with anthracycline-based chemotherapy if it's not been given for the antecedent or previous low-grade lymphoma like R-CHOP. And we have this full armamentarium of approved large cell treatments, which I'm not going to have time to talk about today. I can rattle them off briefly, though. So it includes everything I mentioned in this presentation, more or less so far: CAR T-cell therapy, bispecific antibodies, salvage chemotherapy, R squared. There's also things like tafasitamab and lenalidomide as well. And there's things like loncastuximab tesirine. So lots and lots of other options as well for transformed lymphomas. But I'm going to talk about CAR-T because that was what I presented at ASH this year as kind of a splash. We talked about CAR-T already pretty extensively. As far as the outcomes of transformed lymphomas, previously we only had everyone kind of lumped into one big pot, like ZUMA-1, which is the first axicabtagene ciloleucel study. It has over 5 years of follow-up, but it really had everyone, a big mix of all kinds of different large cell lymphomas, including our transformed lymphomas, into one study. And so the fields really wanted to try to discriminate between certain subtypes of large cell lymphoma, aggressive cancers, and try to see who does better than who. This was one of the signals that was published in 2024, so just this last year, in a French Descartes registry, showing that transformed lymphomas do much better overall than we call de novo large cell. So high-grade lymphomas without transformation. But there was no study previously, this is my cue and for my shameless plug, to look at outcomes of transformed follicular lymphoma in isolation compared to large cell. So this was one of my oral abstracts at ASH this last year, where we actually looked at that exact question with a 14 center study. We talked about, we looked at patients who were treated universally with CD19 directed CAR T cell therapy, which is all of our approved options now. And we looked actually for patients treated over a 9-year span at 14 centers, so the largest study to date. And we also looked at patients specifically with double hits, double expressor lymphomas, these higher risk subgroups, basically. We did some fancy stats. I'll leave it at that for now. We had 705 patients, including our lovely Roswell Park patients included on this trial, just looking back in time, the study, I should say. Most patients were actually treated with commercial CAR T cell therapy, and we used registrational data that's required to look at outcomes, basically. Mostly there was no difference between these populations. Another important thing looking at trials, who's included in what, are some people sicker than others when you look at comparative trials. Ours was, I think, fairly well balanced, except for the fact that transformed follicular lymphoma patients seem to get less CHOP or anthracycline-based chemo. Transformed follicular lymphoma had more bendamustine exposure. Another important clinical pearl is that bendamustine is really good for killing lymphoma, but it also kills T cells really well. So using bendamustine before CAR T cell collection, that leukapheresis process I mentioned with that big catheter in the neck or chest, is a bad idea. Really, within 6 months or so, typically, can still manufacture. We can still do successful engineering of those cells, but it's more challenging, and outcomes are a little bit poorer. So you try to avoid that if possible pre-CAR. The other thing is the subtype of lymphomas are a little bit different between these groups, and that's something to pay attention to. I'm going to just really highlight, I don't want to belabor stats too much, but just know that there was a massive difference between these groups in terms of both median progression-free survival from CAR T, as well as median overall survival. And this is a new signal. I think it's best to describe this as this honestly on this graph, and this is actually overall survival, not just progression-free survival. So patients with transformed follicular lymphoma in this comprehensive multivariate analysis appear to live longer, right? Do better with CAR T. They progress less often, and they're more likely to be alive compared to patients with large cell lymphoma that was not coming from a transformed lymphoma. And for me, that really puts more weight, frankly, to be a little bit more pro-CAR for patients with transformed lymphomas, because outcomes are better and actually survival is better. So it's just one of those important points. I think we're definitely going to be focusing on why de novo large cell lymphoma does not do as well as the transformation or transformed follicular lymphoma. That's going to be in our forthcoming paper. And I would ask you not to share any of these slides too widely yet, because we're going to be publishing them. But I will say that we found pretty significant differences between these groups. So, in my opinion, I think I'm at more than time, so I'm going to cut myself off. You've been too kind, but I'd be happy to answer any questions or concerns. And here's some of my contact information, including my website and our clinical trials website at Roswell Park. And appreciate each and every one of you, and just want you to know that we have your back.
Thank you so much for that wonderful presentation, Dr. Cortese. If you have a few minutes still,
Yeah.
we can do Q&A. Okay, great.
Yeah,
So,
of course. Sorry, I blabbed too much.
no,
Guilty.
that was super insightful and informative. So thank you so much. But if anyone has any questions, feel free to drop them in the chat. And so one question is transformation more common for patients who are on watch and wait compared to patients who receive initial treatment?
The short answer is no, we don't think so. Typically, patients who have a shorter time to first treatment have some molecular characteristics to them, some mutations, higher grade disease. So basically, if there's clues in the genetics. We're still trying to sift out exactly by mutation profile of the tumor itself, but we actually think it's not just the DNA changes, it's actually how the DNA is accessed and read. So we call it the epigenetic changes. That's hot research right now. We're working on that. I'd love to have an algorithm, like an AI generated algorithm, to predict transformation with certainty. That's something that we're working on. But long story short, we think that patients who come in with more aggressive disease, they do tend to transform at a higher rate than others, basically. So if you've been on watch and wait for a decade, you're definitely not at more risk just because you watched and waited. Per se, I know there's a couple studies that looked at that question. They suggest that watching and waiting is bad. You have more cells available that potentially can transform. It's something that's worth noting. I don't know if I believe the data just yet, but call me a skeptic on that particular study. I'm happy to be challenged and debate that, though, for sure. And I certainly could be wrong. But my suspicion, and what I tend to see at least, is more aggressive clinical features typically transforms. It's like already transforming, basically. But that's a great question.
Perfect. Thank you for that answer. And then another question is CAR T available for transformed patients earlier on, or is it only available down the line in their treatment?
So it is available second line. So technically speaking, transformations from a low-grade lymphoma were included in Zuma 1 and also in Zuma 7 in the transform studies. So as far as the axicabtagene ciloleucel and lisocabtagene maraleucel, it's always a mouthful to say those. But basically, they are both approved in the second line setting if this, say you had treatment, say with R-CHOP or BR, and it really came back fast. So you give one treatment of some other salvage and it comes back even after that. So definitely, if you're talking about the large cell from the get-go, it's second line. Transformed from the very beginning, that second line treatment, it's already FDA approved. If you have a low grade lymphoma and I've actually had a couple patients like this where you do the end of therapy scan, their initial workup was only for classical follicular lymphoma. Get to the end of therapy scan, there's a tiny little nidus or rind of disease left, and that actually ended up to be a little tiny amount of transformation, actually. So that I actually would count as a line of therapy for the large cell. And technically, you could talk about CAR T, but we often will challenge if they're anthracycline naive. We have not given R-CHOP yet. Oftentimes, we would try to use a better chemotherapy. Unfortunately, still, I know chemo is dirty and toxic stuff, but it is very effective and can cure lots of people. We often will challenge with anthracycline-based treatment first, and then talk about CAR T if that's not effective. But technically, second line if it's transformed from the beginning.
Perfect. Thank you. And then another question is, what are the chances of lymphoma coming back after treatment for transformed follicular lymphoma?
So that goes back to what type of treatment we used, and then some of the molecular features we're still trying to get better at, and things like MRD or minimal residual disease. So we're trying to find better ways to refine exactly who's going to relapse and who's not. So the MRD-based question, I didn't touch on that yet, but this is a new thing as far as large cell lymphoma. It's FDA approved, but still, it's hard to interpret. It's not widely generalizable just yet, but that is available as a blood test to actually look for residual disease in the blood. clonoSEQ is one of the platforms out there. There's PhaseSeq, and there's a couple others that are actually working on that as well. But long story short, I think Natera actually is working on one as well. There's in the absence of those more personalized approaches to identify who's going to relapse, we have to stick with, unfortunately, with our trial level data. And that goes back to those Kaplan-Meier curves, right? So it's roughly, say with CAR T cell therapy, we showed that it's about 60% chance of being in remission, 3 years later plus, and that's with multiple relapse high risk follicular lymphoma with something like CAR T. So you really have to define what's the treatment, what's the stage. We do have we call them stratified curves to really look at, how does stage 4 compared to stage 2. So if you can kind of input your own disease characteristics into those curves, you can kind of get a better idea of where you might shake out. What are your probabilities? Unfortunately, it's a probability game, and no one loves to live in probability worlds, right? With with cancer, especially. It's like you're rolling the dice, but unfortunately, that's still kind of where we are until we get better at really nailing down who's going to do well and who's not, and then how to intervene, basically, for people who we know are not going to do well. That's coming. Hopefully,
Yeah,
that's a long-winded answer for that question. I apologize, but
no.
we're not great at it yet, to be honest. We have to use the population level trial data for now.
Yeah,
Already.
perfect. Thank you. And then the last question is, how can I talk to my doctor about this if I'm concerned that my follicular lymphoma has transformed?
I would see them in clinic right away. Always, of course, give us a ring at Roswell if you're in the Western New York area, or your local academic center as well. If your community doc is not listening to you, not doing a good job, I would look for another doc. I hate to say, advocate for yourself. Most docs I find are very receptive, and if they are not answering it, it's because they're slammed and busy. But it's not a great excuse, right? If you're concerned, get in for care, advocate for yourself. Um, certainly there's going to be, like I mentioned with the PET scan, right? There's going to be some false negatives out there. Another thing I just want to mention is it's possible if you have an infection, for example, even like a sinus infection, and you have a little more enlargement in your lymph nodes, say in your neck, close to where your sinuses are, and it goes away, right? After, say a week or so, you can rest a little bit easier, right? That probably was what we call reactive lymphadenopathy. But I would always report any concerns like that to your docs, and at least give us a chance to weigh in and tailor your surveillance plan, and potentially get some imaging or biopsies, and take that very seriously. Because if it's truly transformed, we know you're going to do better if you get in earlier and start treatment earlier. Lower stage, less aggressive disease, less beat up, the better, of course, and
Perfect.
very treatable.
Yeah.
So
No, perfect. Thank you so much for, again, that wonderful presentation and your answers to all of these questions. This has been so informative. Um,
good to hear it.
and quickly before we go, I just wanted to highlight a few more upcoming events that we have for patients. And so the link to sign up for these events is down at the bottom of this slide, and I will send the link as well in the follow-up email that we send out. And finally, I want to say thank you again to Dr. Cortese for his wonderful presentation, and a huge thank you to all of you for helping us build our lymphoma community. I've added my email to this slide, so please don't hesitate to reach out if you have any questions about HealthTree or any of our programs. And I appreciate you all and hope to see you all at another webinar soon.
Thank you for having me.